Let's get straight to it. We're running an integrative mixed block simulation designed specifically for that 270-plus clinical reasoning threshold. We're skipping the basics today. Your objective? Isolate precise pathophysiological mechanisms and execute fourth-order management decisions without hesitating. Simulation 1 starts right now.
Here's our first third-order vignette. We've got a 65-year-old male presenting with acute right eye pain, vomiting, and a unilaterally mid-dilated non-reactive pupil. This happened right after he took an over-the-counter cold medication. You need to differentiate between a systemic toxic ingestion and an acute mechanical vision threat. Take a look at these 5 options. To nail the exact management step, we have to rule out systemic poisoning and isolate the precise ocular pathology.
Let's deconstruct the most plausible distractors. You know cold medications are loaded with antihistamines like diphenhydramine, which pack a strong anticholinergic punch. Systemic anticholinergic toxicity gives you a diffuse muscarinic blockade. Think hyperthermia, dry mucous membranes, absent bowel sounds, and bilateral mydriasis. But look at our patient. He has severe unilateral eye pain and a unilaterally mid-dilated pupil. That localized asymmetric presentation completely rules out a systemic toxidrome. Instead, the mild anticholinergic effect of that medication triggered a mechanical blockage. We're looking at acute angle closure glaucoma.
Let's break down the anatomy. In acute angle closure glaucoma, medications that induce even mild pupillary dilation cause the iris to physically thicken and bunch up right at the angle of the anterior chamber. This literally blocks the trabecular meshwork, entirely halting aqueous humor drainage. The intraocular pressure spikes incredibly fast, threatening serious ischemic damage to the optic nerve. That's what you're evaluating when you look for optic disc cupping on fundoscopy. And that massive pressure spike? That's exactly what's driving the excruciating pain, the cloudy cornea, and the autonomic vomiting.
So this brings us to an absolute diagnostic mandate. When you suspect acute angle closure glaucoma based on a rock-hard, red eye, and a fixed, mid-dilated pupil, ocular tonometry is mandatory. You have to quantify that intraocular pressure. That makes option B the correct answer. Hitting them with IV fluids or sending them for a CT scan is just going to delay a vision-saving intervention.
Once tonometry confirms your diagnosis, management has to be rapid and sequential. You need to drop that intraocular pressure using multi-agent pharmacotherapy. First, hit them with a topical beta blocker like timolol to decrease aqueous production. Next, pilocarpine, a muscarinic agonist, to constrict the pupil and pull the iris away from the trabecular meshwork, increasing outflow. Systemic acetazolamide can also be added. It's only after that pressure is medically reduced that you move to definitive surgical intervention, which is a laser peripheral iridotomy.
We absolutely have to highlight the lethal management trap sitting in option C. Administering topical atropine, a pupillary dilator, is an absolute contraindication here. If you induce further mydriasis, you will actively worsen that angle closure, accelerate the pressure spike, and permanently blind the patient. Don't fall for it.
Smash cut to simulation number 2. We have a 4-month-old infant presenting with hypotonia, ptosis, poor feeding, and absent pupillary light reflexes. You're staring down a descending neuromuscular block. Your job is to identify the exact pathophysiological mechanism from these 5 distinct choices by isolating the true microbiological trigger.
This scenario forces you to differentiate the specific pathogenic triggers of botulism based purely on demographics. Adult foodborne botulism, usually from improperly canned foods, comes from ingesting preformed toxin. But infant botulism, often from exposure to soil or contaminated honey, is caused by ingesting Clostridium botulinum spores. That infant's immature GI tract allows those spores to colonize and produce the toxin in vivo. So, option B is the correct mechanism. You can systematically eliminate option C just by looking at the patient's age and route of exposure.
But why isn't this myasthenia gravis? Both of these conditions present with prominent bulbar weakness, ptosis, diplopia, and dysphagia, which manifests as poor feeding in an infant. But the clinical differentiators here are strict. Botulism features a descending flaccid paralysis and, critically, fixed dilated pupils due to an autonomic muscarinic blockade. A myasthenia gravis crisis strictly targets skeletal muscle nicotinic receptors, meaning those pupillary reflexes stay completely normal.
Let's look closely at the synaptic defect. Botulinum toxin cleaves snare proteins right at the neuromuscular junction, physically destroying the docking mechanism needed for vesicle fusion. The result is the absolute prevention of presynaptic acetylcholine release. This exact mechanism drives both the profound dysautonomia, like those absent pupillary light reflexes, and the severe descending bulbar and skeletal weakness.
And that brings us to a strict therapeutic boundary. Botulism is primarily a clinical diagnosis. Immediate administration of botulinum antitoxin, specifically botulism immune globulin for infants, is absolutely mandated the very second you suspect the syndrome. Arresting that descending paralysis and preventing respiratory failure takes absolute precedence over waiting around for specialized confirmatory stool or serum assays. Treat first.
Moving to our final simulation, testing fourth-order management priorities. We have a 32-year-old patient with known myasthenia gravis presenting with worsening dyspnea. Their negative inspiratory force, or NIF, is negative 15 centimeters of water. Evaluate these 5 choices. What's the immediate next step for a rapidly decompensating paralytic respiratory crisis?
Remember, in conditions like MG or Guillain-Barré, patients don't stop breathing because of primary lung pathology. They stop breathing because their diaphragmatic and intercostal muscles fail. We monitor this insidious decline using serial vital capacity and negative inspiratory force assessments. This exact sequence lets you detect impending respiratory failure way before you see overt clinical signs, like cyanosis or accessory muscle use.
Let's apply the absolute intubation rule for neuromuscular respiratory decline. You do not wait for the arterial blood gas to show a plummeting PaO2 or a spiking PaCO2. Elective, controlled intubation is mandated prior to the onset of overt hypoxia or hypercarbia. Waiting for gas exchange to fail in a paralytic patient is a fatal error, period.
You need to know the strict numerical thresholds for intervention. That means a vital capacity dropping below 20 milliliters per kilogram or a negative inspiratory force greater than negative 20 centimeters of water. Remember, NIF is a negative number. A NIF of negative 15 is mathematically greater, meaning it's closer to 0 than negative 20. That indicates profound inspiratory muscle weakness. Our patient's NIF crosses this exact threshold, which triggers the immediate intubation protocol. Option B is the only viable step.
Let's rule out the high-noise distractors. Certain medications directly impair the neuromuscular junction and will actively precipitate or worsen a myasthenic crisis. You must aggressively avoid fluoroquinolones, aminoglycosides, and beta blockers in these patients. If you administer a fluoroquinolone, like in option E, you are actively accelerating the respiratory collapse.
Finally, a clinical pondering to wrap things up. Consider the overarching hierarchy of resuscitation in neuromuscular emergencies. In a severe myasthenic crisis, why must mechanical airway management strictly precede first-line disease-modifying therapies like IVIG or plasmapheresis?
The high-yield answer comes down to pure chronobiology. Airway failure induces lethal hypoxia within minutes. While IVIG and plasmapheresis are the definitive treatments to clear those offending autoantibodies, that immune modulation requires several days to effectively restore postsynaptic acetylcholine receptor function at the motor end plate. You simply cannot bridge a patient across days of paralysis without a secured airway. You must secure the ABCs first. That concludes the simulation block. Keep these physiological hierarchies strict, and you will dominate these clinical scenarios.